Okay, hi guys. Is audio and video everything okay? So shall we start? So this is a quick discussion for the quiz that we did. That is anemia and monoclonal gammopathy quiz. And as I always tell you that do let me know the feedback of the quizzes which we are having. So these are very small quizzes that we are holding. So do let me know if you like them, and we can have more such quizzes depending upon your feedbacks, guys. So these are some questions basically which were given and are important to know in anemia and monoclonal gammopathy. So coming to the first question without wasting much of your time. So this was the first question, that if we are decreasing the concentration of NaCl and we are looking at the degree of hemolysis, what are we doing? So guys, always remember this is a very typical test called as osmotic fragility test. Okay, so osmotic fragility test is done with the decreasing concentration of NaCl. And in fact, you can plot a graph where you're decreasing the concentration of sodium chloride like 0.8, 0.7, 0.6, 0.5. So in normal person like you and me, if we are plotting a graph, our red cells will start lysing at 0.5% and 100% lysis will occur at 0.3%. So this is how we can make a graph. This is normal. But in cases of spherocytosis, any cause of spherocytosis will cause increased osmotic fragility test. So what will happen is that their red cells, because they're spherocytes, so they will not have any excess surface area to take in more water. So they will lyse at 0.7 itself, and they by 0.5, approximately 100% of the lysis would have occurred. So this is what is called as the shift of the curve to right. Okay, so that's very, very typically seen in cases of spherocytosis. Remember, increased osmotic fragility test. So this is an incubated osmotic fragility test that we do. So this is increased in all the conditions where spherocytes can be seen. It can be in hereditary spherocytosis or it can be in autoimmune hemolytic anemia. Therefore, incubated osmotic fragility test is not considered as a diagnostic method for hereditary spherocytosis. So somebody asks you, what is the diagnostic method for hereditary spherocytosis? In that, you should write that this is EMA test. Okay, so EMA binding assay by flow cytometry. So this is EMA test by flow cytometry, that is diagnostic of hereditary spherocytosis. Please remember that. So this is a flow cytometry test. So this EMA is a molecule that directly goes and binds with band 3 and it gives you the vertical bond. If it is intact, then your fluorescence will come. Okay? Okay. So coming to the next question, guys. Okay, so let's look at the second question. Okay. So just a second. Yes. Okay. Good, Lakshit. You were correct in answering this. Okay. So next question was an easy question. And so this was a simple question that if a person has an Ankyrin deficiency, so Ankyrin is one of the most common deficiency in hereditary spherocytosis, what will be the typical presentation? So remember, this is a case of hemolytic anemia, and any case of extravascular hemolytic anemia usually presents with pigmented gallstones. So that's the answer to this question. It is pigmented gallstones. Okay. Coming to the next question. So which does not produce intravascular hemolysis? So this is one thing which everybody should be clear, that there are some conditions which are very typically associated with intravascular hemolysis. So what are the conditions that you should remember which are associated with intravascular hemolysis? So one which you should always remember is PNH. So paroxysmal nocturnal hemoglobinuria. So this is a complementopathy. Okay, so there is excessive activation of complements in this. There is a mutation of PIGA gene in it. So this PIGA gene basically codes for GPI anchor molecules. Okay, so whenever there is absence of GPI anchor molecule, which are these GPI anchor molecule like DAF and MERL? So these are controllers of the complement. So this DAF controls C3 convertase, okay, and MERL controls C5 convertase. Okay, so whenever there is absence of the PIGA gene, there's no GPI anchor, there is absence of DAF and MERL. So this leads to excessive activation of complements, and these complements are responsible for causing three things. One, intravascular hemolysis, they lyse the red cells in the circulation. They can also damage the endothelium, therefore they can cause thrombosis, and they can also basically target the stem cells of the bone marrow, so they can progress into aplastic anemia. Okay, So, or aplastic anemia can coexist with PNH clone. So remember this is one important question. This is an acquired disorder. So PNH is always an acquired disorder. That is one thing that you have to remember. Okay, so this is an acquired disorder and it usually occurs in the elderly patients. So that is one thing that you should always remember. So PNH is usually occurs in the elderly disorder. So what is the diagnosis of choice for PNH? So obviously you have to identify that GPI anchor proteins are absent. So either you identify this with the help of CD55 and CD59, which basically identifies DAF and MERL, or basically you identify it with the help of fluorescent aerolysin, which directly binds to GPI anchor. So remember, absence of flare, absence of CD59, absence of CD55 is diagnostic of PNH. So that is one thing that you have to remember. So any elderly patient presenting with the triad of PIT, okay, so PIT, what is PIT? Pancytopenia, intravascular hemolysis, and thrombosis, you should always think of PNH. Okay, so please remember that. So that's the first condition for intravascular hemolysis. Second condition of intravascular hemolysis, just close name to PNH, is PCH. Okay, so what is PCH? Paroxysmal cold hemoglobinuria. Yes. Okay, so very good, Lakshit. Remember, PNH is a clonal disorder. So it can progress to MDS and AML also. So that is one thing that you have to remember. Perfect. So second condition where intravascular hemolysis is there, that is PCH, paroxysmal cold hemoglobinuria. And this usually occurs by Donath-Landsteiner antibodies. Okay, so Donath-Landsteiner antibodies, which we discussed. I had posted this on my Instagram also yesterday. That I hope if you follow me on Dr. Vandana Pathology at Instagram, you would know this. I posted yesterday. Please see that. And here the target antigen is P antigens of the red blood cells, and it causes intravascular hemolysis. Okay. The third condition where intravascular hemolysis is seen is microangiopathic hemolytic anemia. Okay, so in microangiopathic hemolytic anemia, we usually have HUS and TTP. These are very important that you should remember. Okay, so that is microangiopathic hemolytic anemia. The fourth condition where intravascular hemolysis is there. Okay, so fourth condition where intravascular hemolysis is there is G6PD deficiency. So G6PD deficiency can show you both intravascular and extravascular hemolysis. Intravascular hemolysis it causes, and extravascular hemolysis also occurs in G6PD deficiency. Please remember the morphological hallmark that you see in G6PD deficiencies, Heinz bodies. Okay, so remember that Heinz bodies are very typical. Please remember a very important question that is asked here. Heinz bodies are seen in supravital stain only. So these Heinz bodies are denatured hemoglobin and they are seen only on supravital stain. Remember that point always. Okay. So fifth condition where your intravascular hemolysis can be seen is sickle cell anemia. So please remember, sickle cell anemia predominantly produces extravascular hemolysis, but some amount of intravascular hemolysis can also be seen in sickle cell anemia. So that is another point that you should always remember. Okay. So these are the conditions where intravascular hemolysis is there. Okay. Yes. Yes, Sonal, I will definitely post that, and I keep posting that. So if you go on my Instagram page, Dr. Vandana Pathology, again you will find special on the top. What is that called as snippets, and that Robbins tables are there, which you should revise before going to the exam. It's already there. Please see them. Okay. So when we talk about intravascular hemolysis, so these are the conditions that everybody should remember. Okay. So thalassemia is a typical disorder where extravascular hemolysis is seen. So that was the answer. So thalassemia basically causes extravascular hemolysis. Okay. Now, coming to the next question. So this is a 23-year-old female, and very important question. They were uniformly distributed spicules. Okay, uniformly distributed spicules. So whenever we talk about the spicules in the RBC, remember we have two types of spicules. Either they are uniformly arranged. Okay, so like your alphabet E. So whenever you think of an alphabet E, isn't it like E? So uniform E. Okay, so whenever it's uniform like this, these are called as E for echinocytes. So they are called as echinocytes. Okay, whereas so echinocytes are also called as Burr cells. Okay, so Burr cells. Okay, so B also is like E only. So when you join the two ends of the E, they become Burr cells. So Burr cells are echinocytes. Remember, the most important cause of echinocyte is your EDTA artifact. That's most common. So if you take the sample today, leave it in EDTA and you send the sample tomorrow to the lab, you will see kynocytes. Okay. Apart from that, what is the other spicules? So irregular spicules like A. Okay, spicules like A. Okay, so like A like spicule. Okay, so just a haphazard big spicule, irregular spicule like A. So A alphabet itself is a irregular spicule. So these are acanthocytes. Okay, acanthocytes are also called as spur cells. So spur also is like a big spicule like this. So spur cells or acanthocytes are basically seen in liver diseases. Okay, so remember, when do you see this? So what is the mechanism of this? Apart from, we are studying EDT artifact or liver disease, what's the mechanism? So there's a very beautiful table from Wintrop's. So they say that we have two type of RBC abnormality, which I'm going to highlight for you. So whenever there is accumulation, there's expansion, something deposits in the outer lipid bilayer like cholesterol. So if cholesterol deposits in the outer lipid bilayer, so it will become irregularly spiculed like acanthocyte. So this is seen in liver diseases. Suppose if there is sphingomyelin which accumulates in the outer lipid layer like in A beta lipoproteinemia, then also you will have acanthocytes. So accumulation of cholesterol, accumulation of sphingomyelin will cause acanthocytes. Now, what about echinocytes? Echinocyte is something like EDT artifact. You leave the sample for a long period of time. So it can be seen either in EDT artifact or something like uremia. Uremia is also like blood stagnant there for long period of time. So yes, so in this what happens is that outer lipid layer is just expanded as compared to the inner lipid layer. So it appears as regular spicules. Okay. Apart from that, very important cause you should remember is pyruvate kinase deficiency. So this is apart from G6PD deficiency, the another enzyme which is very commonly deficient in humans is pyruvate kinase. So deficiency of pyruvate kinase typically produces echinocytes. So please remember that point always. Okay. Now, coming to the next question. So this was a simple question on ESR. Okay, so ESR is increased in which of the following condition? And you have to understand. So ESR is a very simple lab-based second year question, which everybody in the second year should also know. So whenever we are talking about ESR, so ESR always, first you should remember, we can do it by two methods, Westergren and Vintrove. And as I've already told you, Vintrove ends with E. So it can be done in EDTA vacutainer, which is a lavender top vacutainer. Westergrens, okay, so a Westergrens is an opposite of Vintrove. So we do it in citrate. It is done in trisodium citrate. Remember, Westergren is a pipette. It is open from both the ends and it's a longer tube, whereas Vintrove's is a tube and it is about 11 centimeter long. And what we can do in this is a one tube because it's a smaller tube. We can do both the tests in this, that is ESR and PCV. So ESR and packed cell volume both can be done in Vintrove's tube, right? Now, if you look at that, any ESR has three stages. Okay, so very simple, remember RSP. Okay, so first stage is rouleau formation. Okay, when the red cells start forming rouleau, then they start to settle down and then they pack. So there are three stages. Of course, settling is the longest stage. So rouleau is 10 minutes, packing is 10 minutes, and settling is 40 minutes. That is why we always report ESR as millimeter of fall in the first hour. Okay, millimeter of fall in the first hour. That is how we should always report. Okay, so once we have known that, we should know which are the conditions with increased or decreased ESR. So increased is okay, decreased you should remember. So decreased ESR is when the RBCs are too much, like polycythemia. Okay, even in microcytosis, they're smaller cells, they can have decreased ESR. Whenever there is any change in the red cells, it can be sickle cells, it can be acanthocytes, so they will not form rouleau properly. So obviously red cells will not settle down. So definitely ESR will be decreased. Of course, proteins are very, very important in ESR. So whenever there is decrease in the fibrinogen or decrease in the gamma globulins, then also ESR is decreased. Okay. So please remember, decreased ESR, everybody should remember. Increased ESR can be seen in a lot of immune, autoimmune conditions also. Even temporal arthritis has increased ESR. Hypergammaglobulinemia, multiple myeloma has very high ESR. Whenever your fibrinogens are increased, fibrinogen is an acute phase reactant. So it increases in infection, inflammation, cancer, pregnancy. So ESR is increased, okay? And macrocytosis, so they're bigger cells, so they fall down faster. So they will have increased ESR. Okay, so in shape changes, macrocytosis is one condition where ESR is increased. Okay, right? Anemia will have increased ESR, and polycythemia, red cells are more, so they will have decreased ESR. So this is one table which I want all of you to remember. So decreased ESR is typically seen in polycythemia, decreased fibrinogen and gamma globulins, any shape change in the RBCs like spherocytes, sickle cells, acanthocytes, only macrocytes have increased ESR. Okay, rest all the shape changes will have decreased ESR. Okay, so that's another point that you should remember. Now, another question on myeloma was this. This is an immunofixation. So how you have to see is, so remember, we do serum protein electrophoresis and immunofixations for identifying which immunoglobulin is increased, and you have to see the definite dark band. So if you look at that, there's a definite band in G and definite band in K. So this is, it should not be a diffuse band like this, because diffuse band means polyclonal. Okay, so whenever there is a monoclonal band, it is a one dense band. Okay, so like in this, you can see there is a band G and kappa. Okay, so remember that. Okay, so that is your IgG kappa. Okay, IgG kappa. So Kiran-Sai HLH is hemophagocytic lymphohistiocytosis. Okay, so this is hemophagocytosis. Okay, HLH. It is a histiocytic disorder. There is hemophagocytic lymphocytic histiocytosis. So this also has low fibrinogen. So that is why ESR can be decreased here. Okay, right. So immunofixation we just talked about. So I told you this is IgG kappa, which this was also an INICT question last time. So please remember how to interpret your immunofixation. Apart from that, I hope everybody knows that normally in multiple myeloma, I have already told you like this. So the first band is albumin, alpha 1, alpha 2, beta, and then there is a polyclonal band gamma. So M spike always occurs in the gamma region. Okay, so gamma globulin region is the region where the M spike occurs. So this is serum protein electrophoresis. And serum protein electrophoresis not only identifies the M band, it also quantifies the M protein. So quantification of the M protein can be done in serum protein electrophoresis. Okay, so that's, look at the second question also. So serum protein electrophoresis can quantify M protein. That's true. SLIM criteria is the myeloma defining events. That is, you need 60%, more than 60% plasma cells. You should have light chain alterations, so more than 100 involved to uninvolved light chains. And last is your, on MRI, there should be more than 5 millimeter lytic lesions. Okay, so these are three criteria which you have to see, and I've already told you story about it in my lectures also, about a case which I saw in my reporting. So this myeloma defining criteria is super important, guys. So if you're remembering 60%, remember this should be clonal plasma cells. That's very important. Okay, so whenever you're seeing more than 60% clonal plasma cell, that is only one type of plasma cell, either kappa or lambda. That's very important. More than 100 light to involved to uninvolved light chains, and MRI showing more than 5 millimeter lytic lesions. Apart from that, there are very two important prognostic markers, that is serum albumin and beta-2 microglobulin. These are two very important prognostic factors of myeloma, right? Percentage of clonal plasma cell is most important. So if you're looking at the classical myeloma classification, you require more than 10% clonal plasma cells, okay? Plus you need a M band, which has to be quantified. Plus you need a CRAB criteria. So if all these three are there, then you label it as a myeloma. Even if these are not there, then you should see SLIM criteria. That is this. That is 60% plasma cell, light chain involved, and more than 5 millimeter lytic lesions. So this is very classical for myeloma criteria, which everybody should be super clear. Right. So next is about myeloma. So this is your POEM syndrome. POEM syndrome is basically a paraneoplastic manifestation with myeloma. And remember, this is given by different name. It is also called as osteosclerotic myeloma, or Crowe-Vicquase syndrome, or Takasuki syndrome. So this is POEM syndrome, which became as very popular paraneoplastic manifestation of myeloma and of monoclonal gammopathy basically, and it has osteosclerotic lesions. Rather, we have seen that myeloma typically presents with lytic lesions, but this is osteosclerotic myeloma. So it stands for something. P stands for polyneuropathy. Neuropathy is one of the commonest manifestations that is seen in these patients. So they present with polyneuropathies. They present with organomegaly. So remember, we have P, O. Now coming to E. E is endocrinopathy. So they also have endocrinopathy. M is very important. So they have monoclonal plasma cell disorder. And the catch point here is that majority of the time, right, 95% of the time, they have lambda light chain. And that is very, very important. And there is also increased VEGF levels in their body. Okay, so VEGF is increased in the body and they have lambda light chains. That's another point that you all have to remember. And then comes your skin changes. Okay, so then comes your skin changes. So that's POEM. It's a paraneoplastic manifestation. Remember, 95% of them have lambda light chain, and VEGF is a sensitive biomarker. Okay, so biomarker of POEM syndrome is VEGF. Okay, so they can present because there is increased VEGF, so there is a lot of leaking occurring. So these patients can have a lot of edema, effusions, papilledema, and a lot of sclerotic bone lesions. So that's very classical for POEM. So that was the question. So question was this. So which is not true. So we have polyneuropathy, we have endocrinopathy, we have skin changes. Macroglossia is a feature which is seen in amyloidosis. So I've already told you this also, that whenever we have primary amyloidosis, so primary amyloidosis should always be suspected. Whenever you have a case of amyloidosis, you should always do a bone marrow examination to see how many clonal plasma cells are present in the bone marrow. Okay, so that is very, very important that you should always remember. Okay, so macroglossia is a feature of amyloidosis. Okay, right. So that was about POEM syndrome. Never forget that. Okay. So next question is, which of the following is a feature of latent iron deficiency? So this was very logical question and many of you marked it correctly only. Okay. So remember, there are three features of iron deficiency. First person is normal. Then we have negative iron balance. Second is iron deficient erythropoiesis, and third is iron deficiency anemia. So once you get iron deficiency anemia, okay, so that is the last stage. So first stage is only when your bone marrow iron stores are decreased and serum ferritin levels go down. Even TIBC levels start increasing here slowly. Okay, TIBC start increasing here. Okay, but the most important finding is the marrow iron stores are decreased and serum ferritin goes down. Once the iron deficient erythropoiesis starts, your serum markers start affecting. So your TIBC increases, your serum iron decreases, your transferrin saturation decreases. Okay, and marrow iron is already decreased. Okay, so basically there are, so the main point here is that your saturation is going down. Okay, transferrin saturation is going down and serum iron levels are going down. TIBC is constantly increasing. Okay, constantly increasing. Once we get an iron deficiency anemia, then you start getting microcytic hypochromic cells, RDWs are increased. Okay, your patient starts developing symptoms of pica. All that occurs in this third stage, that is iron deficiency anemia. So if somebody asking what is a feature of latent iron deficiency, obviously your transferrin saturation is decreased, that's latent iron deficiency. Hemoglobin is decreased, RW is increased, pica occurs. So this is manifestation, last stage, third stage of iron deficiency anemia. Okay, so that's one point that you all have to remember. So these are three stages of iron deficiency, which all of you should be very clear with, right? So that is all, guys. So this is the last question of the day. So this is of the night, basically. Yes. Okay. So what is the best parameter to identify iron status in patients on EPO therapy? So this is a recent update, okay, which everybody should remember. I am sure all of you know what is reticulocyte count. You know that we can do corrected reticulocyte count for the degree of anemia. We also do reticulocyte production index depending upon the hematocrit. Okay, and we do serum ferritin. So whenever a patient is on erythropoietin therapy, EPO therapy, so we need an accurate parameter to assess the iron status. We don't want your results to be confounded, because any patients who is on EPO therapy might have a kidney disease. So acute phase reactants will be increased. So your serum ferritins will not be an accurate assessor. So in that cases, we want to see the hemoglobin content in the reticulocyte itself. Okay, so whether the hemoglobin content in the reticulocyte is improving or not. So for that, we have two important parameters. One is called as reticulocyte hemoglobin equivalent, and the second is reticulocyte hemoglobin content. So both these are done on two different machines. So there's complementary markers. RET-HE is done on Sysmex machine. CHR is on Advia. So both are on different machines basically, but they reflect the same thing. That is hemoglobin content in the reticulocyte. So the first thing that occurs is whenever a patient develops iron deficiency anemia, the iron content in the reticulocytes is decreased. Okay. So different literature and guidelines have given a different cutoff, but a cutoff of 28.5 picogram gives a good sensitivity. So whenever a reticulocyte hemoglobin content goes less than 28.5, that means the patient is developing iron deficiency anemia. Similarly, if you start the patient on erythropoietin, this is the parameter that you should follow up. So if the red H is improving, what does that mean? That means the person is improving. The patient is improving. So that is what is red HE, which you should remember. So any patient on erythropoietin therapies is always follow on hemoglobin content in the reticulocytes. So that's all for today, guys. I hope this quiz helped you and I'm not taking much of your time. With that,